Okay, I think my background is up.
It works.
Hola, Jaime.
Hola, David, ¿qué tal?
สวัสดีค่ะ Hola, Amy.
Hola.
¿Dónde está? ¿En Australia?
Estoy en Australia. Estoy en Sydney.
En Sydney, como David.
Al costado de David.
Just waiting for a couple of minutes, allowing the participants to join, and then we will start.
Question, just remind us, what's the sequence? Who goes first and who will tell us it's your turn?
It will be Sairath who will be moderating this entire session. And Jaime first would be David, followed by Sunanda, and then Jaime.
Thank you.
And Manishi, you'll be showing the slides, right?
Yes.
Great, thanks.
So maybe let's start. It's 2 minutes past 1:30 in my time. Good morning, afternoon, evening to all the participants from all over the globe. It's wonderful to have representations from around 60 institutions today. Great interest. My name is Praveen and I manage the secretariat for the Primary Healthcare Research Consortium, which works towards improving primary healthcare research in low and middle income countries and is hosted at the George Institute in India. A brief intro to the consortium. The Primary Healthcare Research Consortium is a global member-driven body, and it aims to develop, conduct, and disseminate LMIC-led research, address stakeholder priorities to mitigate the research to policy gap, and catalyze a global network of collaborating partners and develop capacity of LMICs to conduct independent research. This is the 4th episode of the Research Consortium webinar series titled Scaling New Frontiers in Primary Healthcare through Research and Partnership. Today's episode will focus on effective pandemic response to primary healthcare. Before we start, a few housekeeping tips. The introductory material have already been shared with you by my colleague Manusi through a Google Drive link. Those who have not received it, it will also be available in the chat box. Also, kind attention to the question and answer box at the bottom of your screen. I would request everyone to post questions in the QA box below. We will address those questions after each presentation. In case we have more questions and the time is short, we will try discussing them in the breakout in the end of the session. Without any further ado, it's with great pleasure I invite upon Dr. Sairath Noknoy, the current Vice President of Royal College of Family Physicians of Thailand and Chief of the Academic Section, to moderate the session. Over to you, Dr. Sairath.
สวัสดีค่ะ Good morning, good afternoon, and good evening, depending on which part of the world you are. Welcome to everyone in this webinar today. We have lined up for you an expert panel who will speak about mitigating COVID-19 response through primary healthcare from a global, sub-Saharan African, and Latin American perspective. In the first presentation, I would like to invite Dr. David Paris, the Director of Global Primary Healthcare Program, Better Care, and Steering Committee member of the Primary Healthcare Research Consortium. He will speak about his latest publication in WHO Seattle Journal of Public Health on strengthening COVID-19 response through primary healthcare. This is to you, David.
Thank you, Sarah, and Raveen as well. Thank you for inviting me to speak on this topic, and welcome to everyone wherever you are. It's great to be a part of this webinar and indeed a part of the Primary Care Research Consortium. So my remit was to give you, I guess, a little bit of a scene-setting presentation on a piece of work we did for a WHO Southeast Asian journal on public health supplement series that was really looking at agenda setting for a post-COVID or endemic COVID era, and what might be the priorities as health systems rebuild, and particularly focusing on primary healthcare. And WHO are particularly interested in, they have a whole series of articles in that supplement. And Manish, if you show the next slide, please, you'll see the supplement. It's a really great body of work from many authors around the world on this issue of strengthening primary healthcare. But we had a very specific task, which is to actually look at what was known about strengthening primary healthcare systems pre-COVID. And I think the imperative here was to say, we aren't reinventing the wheel when it comes to primary healthcare. There's a lot of knowledge that was carried through in the pre-COVID era. And of course, the declaration and reaffirmation of the principles at Alma Ata at Kazakhstan with the Astana Declaration had really set an agenda already for strengthening primary healthcare systems. So our remit in this journal supplement was really to identify what was already known in the literature. And you can see the co-authors on the paper there and the institutions that were involved, and my great appreciation to everyone who participated in this study. Next slide, please. So this is like just to set the scene, I guess, around this issue of health system resilience. And this is looking at excess mortality during the COVID-19 pandemic for 4 countries, plotted through from January last year through to end of July. And excess mortality, as many of you may know, is looking at during that particular time period, how many excess deaths were recorded relative to a 5-year average prior to that period. And what it shows here, I think, is in countries where mortality surveillance systems are reasonably robust, it shows how dynamic health systems were and indeed are during COVID-19 as it's played out. And if you look at a country like the UK in green, you can see in wave 1 of the pandemic in April last year, the excess mortality really skyrocketed, over 100% extra deaths during that period relative to the 5-year average previous to this. And then as the restrictions kicked into place and other measures were taken, that starts to drop, and then there's this recovery phase through the Northern Hemisphere summer. And then when we moved into the winter period, the wave 2 came along, and again, you see excess mortality rising again. And then into the warmer months, it started to recover again. And this has been similar for other countries. And even the US, despite many of its challenges with its healthcare system, exhibited a similar sort of pattern there. But have a look at Brazil. This is a health system that's undergone stress and persistent stress throughout the pandemic, and excess mortality has continued to rise throughout the pandemic period. So it really shows how health systems do go under extreme stress. Some recover and then go back into stress during resurgence of COVID cases. And others actually have been really pushed to the brink and have found it extremely difficult to recover. So this is, I think, an important context in which we think about the rebuilding agenda. Next slide, please. So we grounded our study in the WHO operational framework for primary healthcare, and that's divided into these primary healthcare levers, of which there are 4 higher order strategic levers: political commitment and leadership, governance and policy frameworks, funding and allocation of resources, community and other stakeholder engagement. And then what they call operational levers, the remainders down the bottom there, which is more around I guess the technical elements required to implement care. And so these are models of care, workforce, digital health, physical infrastructure, access to medicines, etc. And so what we tried to do is look at the literature and identify in these where the movement was of examples of best practice across these different levers. Next slide, please. We had an incredibly short period of time to do this work in. And so one of the benefits of working in the Primary Healthcare Research Consortium is that we had already accumulated a larger body of literature for the previous work we had been doing around evidence gap map analyses, which was published in BMJ Global Health towards the end of 2019. And those literature reviews had focused on 4 key areas, looking at primary healthcare policy and governance, PHC organisation and care delivery models, primary healthcare financing, and performance monitoring and safety and quality systems. So what we actually did was a review of the reviews. We pulled out the already accumulated literature in these different evidence gap map analyses, and did a secondary analysis of what we could find in terms of identifying best practices. Next slide, please. So firstly, in the strategic levers, I think there was, and some of these things I should say are not going to come as a surprise to many of you, but the strategic levers are king. They are critical in enabling strong health sector reform and enabling strong primary healthcare systems. And there are many, many country examples of how political commitment and leadership to PHC reform really drove successful agendas in several countries. And this notion of high-level political leadership to integrate health in all policies, taking a multi-sectoral approach, having strong leadership and governance from civil society organizations to not just engage, but participate in decision-making, focusing on strategies to increase demand generation and confidence in primary healthcare systems, and often a long-haul approach. These were years to decades-long reform initiatives that generated results, not short-term political cycles that were going to achieve these results. So countries that really invested back in the 70s and 80s were reaping the rewards in the 2000s and beyond. In terms of governance and policy frameworks, a lot of interesting things around decentralization and how national level policies could be implemented and enacted at regional and subnational levels, and an emphasis on strengthening the middle tier structures of healthcare systems and ensuring that there was a strong middle tier that was both responsive up and down the healthcare system was another key factor that we identified in several countries as being a driver of PHC reform. Fiscal expansion is critical. Many of these strategies need to be enabled by increased investment into primary health care. And many did it through national health insurance schemes, through general taxation. Others had social health insurance schemes for low-paid workers, and others accompanying that with community-based health insurance schemes. And perhaps lower down, some examples of disease-specific benefit packages for chronic diseases. And then the final one around engagement of community and other stakeholders relates a bit to the political commitment and leadership, where there was an enabling environment for civil society to fully participate. And there were many multi-country examples of these studies. That was considered another critical enabler. And on the right side, we thought we tried to identify where these levers work together. So one lever on its own wasn't enough. It was about engaging all those. And you can see on the right, political commitment and leadership just keeps coming up as being absolutely front and center to stimulating reform and success with those reforms. And the next slide, please. And then the operational levers, I think what we found was that they go hand in glove, really, that the strategic levers are a priority and must be there. But that on its own wasn't enough, that there needed to then be translation down to frontline care, changes in service delivery models, a lot of evidence around service integration across medical disciplines, across medical conditions, taking a person-centered rather than disease-centered approach, again, engaging communities, promoting team-based approaches to care, driving uptake of evidence and guidelines into clinical practice. And again, this issue around decentralizing control and governance of delivery of care so that local leaders and local autonomy was emphasized. So a lot of things around models of care. Next slide. A lot in workforce reforms. Just about all of the countries you see there in the second column made extensive investments in skills and capacity development. A lot were looking at really the whole primary healthcare team. So not doctor-centric models, but teams where there was investments in doctors, nurses, mid-level care providers, frontline community health workers, and seeing the power of harnessing team-based approaches across all the different cadres of the primary healthcare system, and particularly a lot of investment in the middle level health workers in supportive supervision, investment in training, etc. Engagement with the private sector, we found less around models, examples of best practice, but a few countries did look at contracting arrangements, increasing accountability of private sector providers in delivery of services, allowing private sector autonomy, but at the same time providing guidelines and frameworks within which that workforce could deliver high quality care. But I think this remains still an area for more exploration, how to meaningfully engage with the private sector. Next slide. Systems for improving quality of care. Again, I think these are well evidenced both in low and middle income countries and high income countries. Things like safety and medical error reduction, optimal use of clinical records, clinical decision support and guidelines, public reporting and performance reporting was another key one. Audit and feedback as part of quality improvement cycles of care. External accrediting bodies, again, on minimum standards of quality of care, and then workforce strategies to retain a workforce so that you could work on building the quality of care provided. Digital health emerging definitely as a key enabler, but what we found around digital health was that often it was the integration and interoperability of digital health interventions that was key. So taking this more ecosystem approach and not focusing so much on the technology itself, but the users of that technology and how it fit into a clinical workflow, how it was supported by other systems of care, and obviously a lot around the workforce that would be using digital health technologies. And next slide, I think is coming to my last one. So yeah, the key messages that we found is that there is a substantial evidence base of successful primary healthcare reforms in the pre-COVID era. The strategic levers are critical, and political will time and time again comes up as being fundamental, but not on its own is it enough that the operational levers are also critical, particularly around emphasis on community-centered comprehensive primary healthcare, investment in primary healthcare teams with adequate supportive supervision, remuneration, balancing regulation and autonomy, and emerging evidence on the role of technology to support these models of care. And my last slide around recommendations for researchers working in this area. We identified 3 key areas where there are research knowledge gaps. One is around integrated service delivery models, another on optimal performance management systems, and the third was around, I guess, the use of evidence and health technology assessments to drive decision-making. There are many others, but these are 3 that I wanted to single out as being important. And we very much supported the WHO concept of embedded implementation research, that the questions and the priorities should really be asked of the people making decisions and providing the services, and for academics to become a part of that conversation, taking a co-design approach is essential. And more case studies of excellence, the ability to systematically capture examples of where best practices are happening is also a key thing going forward. So I'll stop there, Sarah.
Thank you very much, Professor David, for very valuable information. We have a couple of questions for you. The first one is, can you give a few examples of the decision support system?
Yeah, I think there are quite a few, including our own research at the George Institute, that looking at, for example, in effect, translating the WHO PEN guidelines for non-communicable diseases, the algorithms that are in those, and the Healthy Hearts package into decision rules that are deployed on tablet devices for use by health workers and doctors and nurses. And we've done work which Praveen has actually led in Indonesia and India to test that strategy, and shown that it can definitely improve quality and access to care and access to recommended medicines. And there are many other groups around the world who are doing things like that. Be happy to share papers on that.
Thank you. And the second question is, has there been any best practice of integrated interoperable digital systems at a country level?
Yeah, we have got a few examples in the paper about that. One that comes to mind in Kenya is the AMPAT system. So they developed an open source medical record system that's now scaled and it has interoperability. It's put forward as a really strong model of how open source medical record systems can be used and adopted at scale. But there are many others. It is an area, though, of high priority, because a lot of digital health interventions are siloed and end up falling over at the pilot stage.
It seems that's all the questions that we have for. Oh, okay. We have one more question. Could you share a link or copy of the report that was mentioned?
Yes, absolutely. Sure.
Thank you very much. Okay, so now we move on for the second presenter. I would like to invite Dr. Sunanda Ray, who is currently extraordinary professor in Department of Medical Education, Faculty of Medicine, University of Botswana. She will summarize the findings from a supplement on primary health care and COVID-19 that was published in a journal that she's a co-editor of.
Hello, good morning. Thank you. Well, good morning from Botswana. Good afternoon or good evening, wherever you are. I'm just going to share my screen. And I'll also turn off my video because my internet is a bit shaky. I'm just trying to get it onto slide. I don't seem to be able to get it onto the slideshow. So just give me a second.
Dr. Sumendra, do you? Yeah, it's coming.
I think that's okay, yeah?
Yeah.
Okay, so
Perfect.
is that okay? Great, thanks. So what I'm going to do is just show you some examples of work that was submitted and published at the African Journal of Primary Healthcare and Family Medicine, which is where I'm the an assistant editor. And I'd like to recognize Professor Bob Mash, who's also on this webinar as one of the participants. What we did was we asked people, the readership, to send in examples of best practice, but particularly focusing on district health systems. In most of Africa, when we talk about primary health care, frontline workers in primary healthcare tend to be nurses or clinical officers, clinical associates, what's called medical assistants. And the doctors and senior nurses tend to be at district hospitals or mission hospitals, and they're all included in the primary healthcare system, though in some countries, the district hospital and the medical-based practice tends to be called secondary care, but in this instance, we're referring it as part of the primary care system. So this is the journal, the African Journal of Primary Healthcare and Family Medicine. It's the official journal of WONCA, the World Organization of Family Doctors, and also Prima Famed, which is a network which focuses on primary care and family medicine. And we encourage scholarship, particularly from young scientists, but to publish what's actually happening on the ground in sub-Saharan Africa. Okay, so a big focus in all of this is on community-oriented primary care. And just as a reminder, this is a continuous process. It's where primary healthcare is provided to communities, but it's on the basis of assessed health needs. And the aim is that there would be planned integration of primary care practice, but also public health. And just to point out that actually from a discipline, I'm a public health physician and not a family physician. So I'm very interested in how we can join forces, and COVID was a particular example of where this should have been happening. So from Uganda, we had this response that the epidemic, or the response to the epidemic, did not have primary health care at its forefront, and that from the outset, the focus was much more on providing critical care. At central hospitals, there was a big appeal for ventilators, and the focus was very much on tertiary care because that was where people saw the severe cases and the mortality. And so what was seen as downstream action, prevention, education, addressing stigma and fear, those were opportunities that were lost. And I think we're seeing the repercussions of this, particularly around vaccine hesitancy as a result. But also a lot of primary healthcare is provided in the private sector, particularly private practice, and this was not used as a resource for education. But on the community orientation aspect, as David said earlier, countries where they already had a well-developed system tended to be the ones that responded in much more quickly and in a more organized fashion. So in Cape Town, where their metropolitan health services have already a strong commitment to community-oriented primary care, they were able to facilitate an adapted community response to the outbreak. In Uganda, they also have decentralized health services with village health teams, and there the public health mobilization was around health promotion, teaching about hygiene, using sanitizer, and particularly carrying forward government policies, like when there were restrictions on funerals and gatherings, but just a reminder that this could also be coercive, in that health workers were used to restrict people from carrying out activities. And one of the papers we had made a very strong protest that social mobilization should actually be at the top of the agenda rather than an afterthought or at the bottom of the agenda. And these are quotes from the paper. The essence of a lockdown is to deprive citizens of their freedom, but importantly also their agency. And the comment was that they ended up being treated like children or as prisoners, that it reinforced their sense of powerlessness, created resentment and fatalism, which actually none of these emotions actually help people to respond in a cohesive way to something like an outbreak. Another comment was that it disrupted their livelihoods, this threatened their survival, it undermined trust. But importantly, for example, in Zimbabwe, there were a lot of pictures of people continuing to crowd into public transport, continuing to go into markets. And this was really because people were dependent on that daily wage from which they fed their families and paid for their other bills. And that these realities for people were not taken into consideration. So again, in South Africa, the role of the community health workers, who were an essential part of the COPC program, was that they embedded these health workers in many of the programs. So they assisted with screening for COVID in communities, mainly using symptomatic screening. But this was undermined by the lack of investment in the laboratory services, and the long turnaround times meant that community screening was not successful because the principle of following up contacts to isolate them didn't work because of the time it took to get the results back. So the community health workers then went to screen households in their area and then referred people who were considered more vulnerable, who had symptoms or those with comorbidities. The community health workers also played an important part in carrying packages from centers to the community, particularly for vulnerable people, medications, equipment, supplies, etc. In some places in Uganda, for example, they actually were responsible for distributing food. But in Uganda, the complaint was that they were underutilized as mediators between the formal health system and the community. One of the issues that came up was whether our health systems in sub-Saharan Africa were resilient or not. And just a reminder of the definition, that this is the inbuilt capacity of a system to sustain provision of essential health and health-related services, even when challenged by outbreaks, disasters, or other shocks. And the conclusion in many reviews has been that most health systems, according to this definition, were not resilient. So for example, many of the services which are provided in primary health care for maternal and child health, for TB, HIV, non-communicable diseases and communicable diseases, many of these came to a halt or were substantially undermined. And the WHO warned that if the focus on C19 disrupted malaria interventions, then we could see a doubling of malaria deaths. And this seemed to be borne out in many of the countries. And also because the symptoms associated with COVID were very similar to those associated with acute malaria disease, there was a lot of stigma and fear associated with COVID with malaria, because people were afraid of being diagnosed with COVID. And some of the publications suggested solutions like the integration of services to widen the scope of the staff who were involved, who could be brought into carrying out essential services, other task shifting measures, but particularly becoming much more integrated with other sectors and using NGO partners. we'll come to the use of IT in this. Some of the examples were reorganizing health services, decongesting, freeing up capacity, separating people into different streams. There were a lot of difficulties around screening and testing. So people, where services were dependent on focusing on people who were positive, this was very difficult. And there were suggestions about staff being screened so that they weren't coming in with being infective. These were also found to be ineffective. Appropriate care at district hospitals. This was a huge opportunity, and I hope we'll build on this in future times, but actually having effective critical care at district hospitals would benefit a whole range of other services, trauma, maternal health, etc. But this issue about having oxygen concentrators, oximeters, training health staff in fundamentals of critical care so that people with moderate illness could be looked after at those centers rather than sending them into central hospitals. And a number of suggestions were made about resources that were available to do this. There was a very interesting example of critical care being provided at a conference center in Cape Town. It was run by family physicians in conjunction with emergency medicine, but the key principles and values of family medicine that supported this whole process, which were very beneficial, were these which are listed on the right. In particular, upholding the humanity of patients, clear leadership and planning, multidisciplinary teamwork, and so on. Now, the use of IT, I think, was one of the things that was at the forefront of this. And I have to say that my personal experience was that in some ways we developed communities which were not what people conventionally think of as communities. So people got information through WhatsApp groups, people passed guidelines and evidence-based research around each other. So these were sort of like horizontal communities through the IT system. But in addition, there were a lot of ideas about how to use IT to keep people's spirits up and to maintain psychological well-being, as well as helping prevent health staff from burnout. But using telemedicine and toll-free remote lines for patients, to give patient education, but also to help people where families were separated from patients, so that you used tablets, for example, for contact between people. And this was in particular with the care of the vulnerable, where we wanted to keep the elderly out of clinics so that they weren't exposed to infection. And this was a way of doing it. And then finally, the whole issue about adapting the clinical environment. We've been doing this now for 18 months, and it's completely disrupted the training programs for many people. And so there were examples of how web-based learning, virtual learning platforms could be used to carry on their teaching, but in particular to adapt the way trainees were having to work in health systems, so that they saw the maximum teaching benefit and learning benefit from the cases that they were seeing. In particular, patient management algorithms, really emphasizing that adapting to a crisis is a key skill to be learned in both public health and family medicine. So these are the challenges which need to be turned into opportunities. We all keep talking about health system strengthening, the need for leadership and advocacy, but in particular moving towards this integration between public health and primary health care, but also involving emergency medicine and a range of other disciplines in actually working together to manage these outbreaks, because it's clear that this is going to happen more often in future, but also for the biggest challenge that we're facing, which is the impact of climate change on the health system. But we need to focus a lot more on local investment in manufacture of essential supplies. Our vulnerability in this pandemic has really been shown up in our dependence on other countries, other continents, in Asia, China, India, etc., for provision of basic supplies. And when there's a global challenge, we're the ones that fall off the edge, as we can see now with the vaccine, the inequitable access to vaccines. That we have opportunities to really use information technology, linking up high income, low and middle income countries. But so long as we don't have equitable access to data and IT equipment, actually there's a potential for the divisions to become greater and for the global inequities and inequalities to become more severe. So that's how I would conclude now, that really if we're serious about reducing global inequalities, let alone inequity, then we have to consider the way in which different communities have access to resources, not only internationally, but within nations. Thank you.
Thank you very much, Professor Sunanda. She has highlighted about the care and service and how the system has adjusted during the COVID-19 pandemic. As the presentation said, although there are lots of efforts on community-oriented practice, if asking if how much healthcare has been resilient, there's still a long way to go, as lots of challenges. And there are a few of questions asking for you, Dr. Sunanda. The first question is, how was logistics of the specimen transport, documentation of test reports managed?
Okay, so the whole issue about specimen transport, as you can imagine, was a major problem, particularly at the outset when the centers that were doing the laboratory work, the testing, were mainly in central hospitals. So if people were tested in more peripheral centers, then there was a long delay in getting results back to people because of the transport issues. I think in Uganda, there was only one laboratory that was actually doing the PCR testing. So in the beginning, this was a really major problem. And I would say that this was a cause of a lot of underreporting of people with COVID, because there was no point testing them because it took so long to get the results back. It improved after a while, particularly when test kits became more available and they could be distributed to the peripheral areas. But one of the problems then was that people started using rapid tests, even the rapid antigen tests when they became available, which of course has a lower rate of
it seems that, okay. So this, Dr. Sunanda, can you hear me?
Yeah.
Okay.
Yes, I can.
Yeah.
Sorry, it breaks up a bit because of the internet instability.
Okay. So the second question is, many countries are revisiting their national pandemic response plans. Any example of countries in which family medicine is being included in the process of developing plan?
Well, there are people on the site, Bob Mash and Steve Reed, who are better positioned to answer this from the South African perspective. But I would say that in most other countries, the family medicine programs are actually not as well recognized to include them in the National Pandemic Response Plan. And this is one of the problems, that they're not actually at the table. In South Africa, I think they were very involved with the whole planning process of responding to COVID. But in the rest, in other countries where they have family medicine training programs, I wouldn't say that they were, but there may be other people in the meeting who can answer that. Bob Nash has a question saying, is the work you presented published? Bob and I have actually written a paper based on the first 27 publications on this, which is awaiting publication. It should be coming out in October. But just to encourage people to look at the journal, because there are new articles being published on the COVID response. And then the last comment, shall I read that out?
Yes, yes, go ahead.
It says, I think the degree to which primary healthcare efforts are being allowed to be implemented depends on existing national, political, as well as socioeconomic characteristics. I noticed that political will as a critical enabler in your review, but not socioeconomic conditions. Was your review not focused on that, or were there no reviews about socioeconomic conditions? I'm not sure actually if this question is aimed at me or at David's presentation earlier, but I should just say that from the point of view of the review we did on papers that were submitted, we could only present what people sent to us. So I wouldn't claim that what we reported was representative of what's happening in all countries in sub-Saharan Africa. But the issue, there were some people that commented that that really the socioeconomic basis, particularly for prevention, has to be taken very seriously, because if people are not able to socially isolate, then if that's a key part of the strategy of preventing transmission, then that's difficult.
Thank you.
Yeah. David is typing an answer, so.
Yeah, maybe I'll talk because I can speak quicker than I can type. There was another enabling around resource mobilization and financing reforms. And you're right that the expansion of political will aligned with increasing economic growth at the national level, and they go together. Obviously, as resources were able to mobilize through general taxation and other finances, funding, fiscal space coming in, aligned with the political will, there was greater investment in primary care reforms. Our review didn't kind of get down below the national level in terms of socioeconomic conditions that we're enabling at the regional or grassroots level, but that comment's very, very true, that there needed to be both together.
Okay, it seems that we have completed the 4 questions for now. So I'm moving on to the last presenter for today. We have Dr. Jaime Miranda, who is a research professor at Department of Medicine, School of Medicine, and the Director of Chronicles at UPCH in Lima, Peru. He will speak on mitigating an effective pandemic response with examples from Latin America. The floor is for you, Dr. Jaime.
Good afternoon, everybody. Can you hear me? And
very well.
Thank you very much. Okay, I was invited to provide some views from Latin America, and I've decided to focus my presentations to understand more on the broader context of the Latin American continent, so that you can have an idea of all these concepts that have been presented take place and play a role into understanding how the epidemic has evolved over there. This is a bit about me. And let me start with all the thank yous to all of you and all of our colleagues on various fronts who are dealing in a way or another with this pandemic. So massive thanks to all of them. Latin America, as of August 9th, there was this report, and I think two messages of this image. If on one hand, the pandemic forced people off the streets, on the other hand, it exacerbated all of these problems. In a region that has 8% of the global population, but has suffered 32% of COVID deaths. And that dramatic sort of discordance is, we need to understand why, understand that all these major drivers that translate into poor or worse outcomes navigating through the existing deficiencies that we know from the primary care level. So two messages here: the size of the problem, the size of the suffering, lots of deaths in the region, and secondly, how crisp and how the tensions between populations and the states has been quite dramatic. Just before the pandemic, you might have heard the stories of Chile, and Chile people going to the streets and swapping governments. In Peru, presidents being resigned. In Argentina, going to a major crisis. In Colombia, early this year, kids being killed among protests because of trying to change the basic allowance of income. So in this very convoluted situation, this pandemic comes in and just devastates. So Latin America traditionally depicted by its inequalities, and that I use this slide a lot, which is quite telling, isn't it? So this is Brazil. And you have these areas that can very well be, based on their indicators, Europe or the high income settings. So life expectancy over 80 years, whereas in just 10 meters apart by the fence, you have life expectancy 67 years, a difference of 13 years depending on where you are in place, and so on. So so these inequalities are very, very present in Latin America. This is the irony of this heading is before COVID. It's burgeoning cities face catastrophe, and it was on the projections of population size and population size in cities and the concept of mega cities. So Latin America will be hosting, this is already an older slide, 2007. The size of the bubbles are the population size, and the red ones are how many of them will host more than 10 million people, and what is called mega cities. So we see across many places in the world, but quite a few of them in Latin America having this dramatic demographic change and this dramatic urban to rural to urban migration and urban increase. And this gets installed into a population that I call carries these long-term handicaps. So just to give you a snapshot of Peru, between the year 2000 and to date, we see this, what is being portrayed as an advancement. So the reduction in chronic anemic nutrition has been dramatic, but I want you to put this back in the history, 20, 30 more years before the graph. And if the line here starts at 30%, when I was born, that line was at 50%. So 1 in 2 of my generation are current adults of a population with very high levels of undernutrition. And that on itself will have repercussions on the individual biological capacity to deal with diseases as well. I don't know where these pictures are from, but I could bet this can be anywhere in Latin America. And you may know very well these perceived assumption that the health system can absorb and to do more, right? So, and if you start with this weakened structure, just by adding more doesn't necessarily solve the problem. So when I see this picture, I don't know, ironically, I don't know, it's my Latin bias or whatever, I think of health systems. And because we never had the chance of starting something with the capacity to accommodate and to serve all its purposes. And we have seen now, and again, Latin America, but in many parts of the world, how this model of adding things hasn't worked at all. And this is very telling in terms of the numbers. So you see here excess data. I think David was mentioning to that, and he had a graph. This is a complement of that graph of the monitoring of excess data. Pretty much when you compare the number of deaths, you may not know the cause, but you know that that there's a figure, there's a death record there, and compared to previous the same time in previous year, there's an increase. So in here is comparing to prior to 2000, and the red hand side is more than 200% increase in excess death. And here in this line number 3 is Peru. So period after period for 2 years, and in a way, these reflect the waves. The excess deaths have the indicator of excess death has been very telling on the pressure of the pandemic throughout. See down the line, you see more lighter levels, and even in Germany, a very different story of the pandemic. Pardon me. And those overall statistics definitely do get translated into individual or more kind of one-on-one or experiences. And yeah, the capacity of the system has been very, very much overwhelmed. And well, my description of the COVID, as a Latin American person, my description of the COVID pandemic is that we were praised as a region on its economic growth and how good it was. Yet the pandemic came like this abrasive chemical that removed all of a sudden our partial blindness to the major inequalities that exist in the region. Apologies for the Spanish, but I'm glad that Sarah and David will be able to understand these slides. I had 3 slides in Spanish, no more than that, but just focus on the colors. Just focus on the colors. The message of this slide is, at least for Peru, this is for Peru. Our health system has been structured in a way that is very hospital-centered, right? So that's the top layer, the red one. And it goes across all the numbers. So in terms of budget allocation, that's presupuesto. In terms of human resources allocation, and in terms of supplies. Everything pretty much, I mean, the large numbers get swallowed up by the hospital level. The middle level less so, and the primary level even less resources. When in reality, the theory and or the expectations, we would love to see that there is more of this allocation following the shape of a pyramid, isn't it? Where because the primary level is the one who has the ability and the capacity to see many more people. So we have that discordancy, right, in terms of how the structure operates, the resource allocation, and where the emphasis are. And that's a measure that has been ongoing for a long time. And I think this is a reality, but I'll be on my optimist side. I will put this as an opportunity. I think is the value of primary care gets to be promoted front and center, because we have all seen how, depending on hospital level system, it's an indicator of failure. Latin America has failed, and has failed big time. Bear with me. This one, in terms of just within the first year of the pandemic, comparisons of point of care. I mean, how many consultations were made comparisons between year 2019 and 2020 here. And you see, yes, people, because of the pandemic, use less services, and we see an average reduction of 15% less utilization of services. And it was both in urban and rural areas. And in a way, that's what others have been telling, the disruption of services, the disruption of chronic care, and so on. And unfortunately, this was should have been a moment for praise, that Peru made it to the front page of the New York Times, and it was through to this very sad news that the system was exhausted at capacity and in various fronts. So even the deaths, people couldn't collect their dead bodies, and for the first time that health receives sufficient attention. So my reflection then of the pandemic and from an emphasis on, and with an emphasis on primary health care is that we need to understand this context pre-COVID, right? So public health preparedness as something that it was absent. So this idea, Latin America was very used to dealing with outbreaks, but outbreaks were contained, usually jungle, tropical areas, less so in urban areas, but the concept of epidemic or pandemic preparedness, zero attention, zero protocols, and obviously zero budget. And this idea of learning how to react and how to react quickly wasn't there. So everything was new, no protocols, no experience. H1N1, previous pandemics, avian flu, SARS, they didn't make it to Latin America. We never heard of them. So this concept of being alerted was all very new. So it caught us unprepared in a structural, because of long time under finances, unprepared because of not knowing how to deal with this and with low resources. Political cycles, I was telling at the beginning of my slide also how in between these cycles, we've seen how health services get more and more underfunded, and it became obvious in this pandemic. But also political leadership and science. As an example, Peru has changed 5 Ministers of Health in the last year. So that's the environment where you have to operate and you have to react, and there is limited room for long-term goals. And Peru is not the exception. I think Chile has changed 3 ministers, Argentina has gone 2 or 3 as well, and so on. So stability and an environment is stable to do long-term planning and long-term projections is not there, and we pay the price. And this is duality of graduating economies. While graduating economy, you've seen, or you may have heard of many countries transitioning from low-income countries to lower middle income countries, and then high income countries. The example is Argentina. Argentina traveled within the last 10 years twice in between the rankings. So Argentina has gone from lower middle income to upper middle income, even to high income. I say, no, please move us back. And so that's everything changes in economic views. Everyone, you want to attain, you want to progress, you want to graduate, to tell the world that we're doing better. But the reality is that behind the scenes, there are many weaknesses to move on that. Chile is on the high income setting. Brazil is not. We only have 2 low income countries, Haiti and Bolivia, I think, and then quite a few of lower middle income countries. But so my message there is that even though the countries are progressing on average, and I know these international averages, this progression is very new, and it doesn't reflect long-term structures of stability and reducing inequalities. And hence my next reflection of health systems. So we have health systems as weak as Haiti, very poor, devastated then through the earthquake a few years ago, and then the cholera pandemic, and all the way to Argentina and Brazil with massive investments. Argentina is an example. We hear very little of it. Point of care services free. It's an entirely state-funded service. Yet for we in Latin America, we tend to look more to the US than to Argentina. and it's irony. So Chile, Colombia, and Peru and Ecuador would like to copy this more European and also, well, actually more the US centric type of models, which very individual based. You pay out of pocket, you have your insurance and your premiums and so on, but less on the strengths of countries such as Brazil and Argentina, because it doesn't give you votes, and they suppose this dichotomy of economy, the private sector, the roles of each of those sectors, and so on. So we have a heterogeneity of health systems in the same region as well. And it's in that environment, and it's in that larger, broader context where that primary care sits in. And obviously, as you all know, this is nothing new. Primary care ends up being the little brother of hospital care. I show you that it's light on terms of resource allocation and priorities. And therefore, by being that weakened type of service, we have a primary care service that is very limited in the scope of activities. It's traditionally very reactive to vertical programs, less experience with chronic care. And the pandemic has shown how chronic care has been disrupted. To move forward, I'd say on the optimistic side of things, so opportunities, yes, we've heard about telemedicine, digital health. We saw that this model of hospital-based type of care doesn't have more capacity, but we need to reach out to people, and we need to be much more agile to reach out to them. So telemedicine now is having ears. I second the message from my previous speaker in terms of integrated services. We won't be able to afford services for every single condition, so we need to be much more proactive in promoting this agenda of integrated delivery models. Otherwise, we won't have sufficient resources for every single one of them. And when I mentioned here the political agenda is that not only people within the health sector, but also others are now seeing the failures of a hospital-based type of system, and we're gaining advocates in other areas to promote primary health care, and that's good. We need more allies on various fronts. On the more closer side, I'd say this element of emotional well-being and burden, not only above all with professionals, all of our colleagues who have been living behind a mask for the last 18, 20 months, and these people haven't had a break. It has been very, very intense, and the toll that I can imagine they're undergoing, it's enormous. So a lot of work to do to prevent burnout and to facilitate coping strategies will be very much needed. And equally in terms of the population, let me change here because I'd say my solidarity with the orphans. It's been calculated in this modeling study that Peru alone ranks top in the world in terms of the number of orphans that this pandemic is leaving. So just up to early this year, I think the numbers were around 100,000 people. So that's a new generation of populations whose social networks and social capital will be enormously reduced, and will bring more challenges to the entire country. So I wanted to reflect on those kind of bigger pictures behind, so to be able to provide this setting, this scene to understand where primary care operates, because we have to admit it doesn't operate in isolation. It's very much interlinked with many other services, and there are many challenges on various fronts, from the population to the more societal environment. So I would like to end up saying Latin America, mucho gusto, but I think the pictures and the story of this pandemic are very grim. So, but on the optimist side, I hope that primary care deserves the attention that it receives the attention that it deserves, rather than having to compete with for the allocation of resources that has traditionally been the case, more on the curative side of the scenario. So I'll stop there. Thank you very much for inviting me to share about Latin America.
Thank you very much, Professor Jaime. The information Professor Jaime has shared has highlighted the same problem that's happened in many places around the globe, that resource and allocation are very much hospital-centered and oriented to the hospitals when primary care has been quite neglected. And the healthcare services, essential cares that are needed at primary care has been affected largely by the presence of COVID-19, both in terms of maternal and child health, chronic diseases, and in sub-Saharan Africa with early detection and care for malaria. So we have a few questions, a number of questions in the Q&A box. I will start with those that is oriented to Latin America first. From Bob Mash, why did Chile do so much better than in terms of excess death? This question for you, Jaime.
Yeah, and can I ask you a favor? I think I've lost my cursor, so can you stop sharing my screen? I don't know, or has it stopped already? I
think it's Munish. Munashi?
Yes, I'm trying.
Yeah.
Okay, thank you. So I'll handle that over to you. I'll focus on the question. So okay. Why has Chile done better? I think, and it's right. It goes all the way through prior larger investments on primary care in the past. That's one. Just something as basic as family medicine having more buy-in. So a tiny factor, Chile was able to hire Venezuelan doctors of the internal diaspora as well to locate physicians in more isolated areas, and maybe my Chilean colleagues will criticize me for saying so, but I've seen them. And so in a way that must be a plus. and also the larger amount of resources invested. There has been also difficulties with handling figures and numbers, and a lot of criticism within the country, Chile in particular, on how the statistics were handled and communicated. Yet it hasn't done as bad as Peru or Brazil, for that matter. So I'll stop there.
Thank you. And to what extent are public health and primary care integrated in Latin America?
I'd say in general, very limited. Very good on particular programs, vaccination and maternal and child care. But beyond that, when you look at the true concept of primary care, of being engaged with communities and driving health from the community side, less so on that front, less so.
Okay.
And I have to admit, one element is also, we don't have to run away from this, but it's also the professional, how stupid we are within our profession. So to a certain extent, primary care in some countries doesn't have the same recognition as in other countries. So in Latin America, we have also that model of training, which is very specialty based and more, if you're a good doctor, if you have a specialization, and that's not sustainable. So in a way, we also have that thing that doesn't help us internally, isn't it?
Thank you. And another question from Bob Mash. When the total health budget is already constrained, how do we ensure that primary health care gets prioritized rather than tertiary hospitals?
It's difficult for many years, difficult to convince. And in that very weak political environment where, at least in Peru, every year of all the prime minister presents its cabinet, and you know that health and education are the ones going to be sacked up just to sustain government. So in general, rather than fighting for budget allocation, if I were to choose, I would fight for not for budget allocation, but for sustainability in leadership.
Thank you very much. And I think Dr. Sunanda has something to add.
Yeah, I just wanted to say that I think this is probably a question for the whole group, but one of the issues is that there are often a lot of people at leadership level who have an MPH or whatever, and they're seen as being the public health drivers in a country. This is, well, mainly in my experiences in sub-Saharan Africa. But the issue is, how do we get beyond the rhetoric of primary health care? You know, the governments always sign up to these declarations, but how do we get it actually into practice? With COVID, because the mortality was in tertiary hospital, the main thing that people were trying to prevent was mortality and the serious cases. And this is why the whole focus was on ventilators and oxygen concentrators, etc. And that was all based around tertiary hospitals. It took them a while to realize that actually they needed to be strengthening services at district hospital level so that people didn't get to that point. And I think this is something we have to keep pushing for the next. Primary healthcare in many of our countries is mainly doctors in the private sector or nurses in clinics. And nurses, apart from a few who are specialists or academics, nurses don't have a loud voice in this. And so this is where, in a way, even though family medicine is very under-resourced, family medicine has to fight to be at the decision-making table and the planning table alongside colleagues in public health, because public health tends to be population-based and primary healthcare tends to be seen as individual-focused because of the private sector. So I would say this is a challenge for us, but we know how to do it, so we need to get on and do it.
Thank you very much, Professor Sunanda. I think this is a very important question, and also would like to invite Professor David to answer this question.
Yeah, I was just going to say there's a question related in the Q&A about the role of civil society in this in moving these debates, and I think it's absolutely critical. There's many examples in we saw in the review, but more broadly, of how the advocacy agenda to push that political will is so critical to enabling investment in primary care. And the other comment I'd make is that once a foothold is made to get some of these reforms in place, the people vote with their feet in terms of endorsing these reforms. And we know, for example, in Costa Rica, that when those reforms were made, they became almost untouchable policies to any government of any side of their political persuasion to change, because the people demanded this and it became normal to expect this kind of service. And so I think there's a huge amount to overcome in terms of inertia, but the role of civil society in driving and sustaining the agenda is absolutely critical.
Thank you. Now I raise a question related to vaccine. How is the vaccine hesitation in each region, and any suggestion on how we should deliver vaccine to health workforce? Maybe to Dr. Sunanda.
Well, I think I mentioned earlier that this whole issue about vaccine availability underlies a lot of the problems we've already discussed. One is the fact that most countries in sub-Saharan Africa haven't had access to the vaccine. So, that's a challenge globally, because variants will keep emerging so long as people are not vaccinated and make their way over to richer countries. So that's the first thing, is equity and access. But then the second thing is that looking at what are the underlying causes for vaccine hesitancy. One is that the internet, even though I see it as being a huge instrument of democratization of health literacy, is also an enemy, because the whole issue about what the dangers of vaccines were carried through churches, through WhatsApp groups, etc. And so we were constantly having to fight misinformation. The issue about microchips and whether RNA was going to transform our genetics and all of these things. So the need for continual education of communities is also important. But understanding why people don't trust their governments when they give out information underlies all of this, that communities don't, even with the lockdowns, you could see the people didn't trust that this was in their best interest. They felt that the lockdowns, the other restrictions were to protect rich people and not to protect poor people. And this is where community activism using CSOs or using community health workers or whatever becomes really important, that there's a continual flow of information and to become trustworthy, that people will accept what you say. I think when people began to see the data that people who were vaccinated were less likely to end up in hospitals, then the queues built up for people to get access to the vaccine. We do follow what's happening in rich countries. So now when people are talking about boosters or vaccinating children, when we see most of our adults are not vaccinated, that becomes a problem. So yeah, it should be something that's taken up by health advocates and activists about equity, but also about education.
Thank you very much. Another question about resilience of health system. What are comments and suggestions from WHO to the continents where other health issues need attention with limited resources? these questions to Dr. Sunanda.
Well, the thing is that we can already see that our other programs, now we have to start from scratch to rebuild them. I think with each major outbreak, there was a lot of data about the impact of Ebola in West Africa, for example, that maternal deaths went up, child deaths went up, people, not just because resources were diverted, but because people were fearful to go to health institutions. So we have to start from scratch, rebuilding trust, getting resources back into the system, encouraging communities to go back to health centers, to institutions, and getting the governments to pay attention to it. But maybe David can respond from the review that he did.
I'm not sure if I can answer it, but I know that some of you might know about the WHO Pulse survey work, where they were looking at essential service disruption during, and they did it in 2 time points through 2020, and I think there might be a third one planned. And with that data, they looked at the country level modeling work on reinvestment decisions. What might be the benefits to countries from reinvestment, and at what time frame it might need to restore functions of essential services, or indeed go beyond what they were pre-COVID. And I think what they're intending to do with that is to try and provide those data to member states as a, if you like, a kind of a decision-making tool on what might be the investment priorities in the rebuilding agenda. So that's one example of the sorts of things that I imagine many member states are looking to decide now.
Thank you. A question for...
Sorry, just before we move on, I think that I really can't stress enough how I think this has been a dress rehearsal. It's a dress rehearsal for things to come. I think that we've had other outbreaks. We've seen how, the cholera disrupts health services wherever Ebola has disrupted health services, and people have to build up. But the real challenge is going to be climate change. And when Cyclone Idai hit Mozambique, a whole city was flattened. People who were rendered homeless during that time have not yet been rehoused. And this is going to happen more and more. Africa will carry the brunt of it, even though we contribute very little to global emissions. And so we need to get the structures set up, emergency planning, emergency preparedness, working with communities. If we don't do this, then we're going to be decimated even further. And so we should see what's happened with COVID as a dress rehearsal and take it very seriously.
Yeah, I completely agree, Professor Sunanda. COVID is actually part of climate change, and we are still will be continuously affected by climate change and need to be prepared for what is coming. Another question for Professor Jaime. The question is, I understand that land ownership structure is one of the main factors for health precarity in Latin America. What do you think about it?
I think you're right. I think the potential to live a decent life in the region, in terms of with all these expectations and with a very poor, if not absent, social protection system, it puts you in those very vulnerable situations. Latin America has had a lot of urban growth, but pretty much unplanned urban growth. You have the images of the favelas in Brazil and shanty towns in Peru, some of the pictures that I have shown. And I think Latin America carries these what's the word? Expectation that if you move to a big city, you will have better chances. And I think COVID is putting that on the balance again. Is that true? Maybe before the internet, you would have better chances for education, and then you could move up on the social ladder. But right now, with mega cities, poor jobs, low wages, absent social protection, I think the endurance to get through it, it's very difficult. And so I don't think millions of people in Latin America had very clear chances or of having adequate housing with services. Many of the costs of Peru, most of the urban areas, grow by what is called invasions. So you invade on the expectation that the government will recognize that, and that will be your land ownership. And then you build, and then you stay there and you progress. But that's very fragile, and it's very burdensome. So putting people first, it's a priority. And yeah, many of the stories of Latin America are difficult. Yet we only see one side of the story, which is the side of growth, and we're only tipping the tip of the iceberg, isn't it? Those who do well.
Thank you. The next question, how much has the past investment in community people empowerment affect the success or recognition of primary health care prior to and during the COVID-19 pandemic? The question for you first, Jaime.
Difficult one. I feel difficult because affected the success of recognition from a care in the pandemic. I think I'm living through the pain of not seeing any success so far. And
unfortunately,
yeah. Having said that, I think most of the positive narratives in terms of community organizations will perhaps derive from examples in rural areas, exemplars in rural areas rather than urban areas. I think urban areas have portrayed and have shown this very individualistic societal approach, and it has left out lots of people. Maybe most of the community people empowerment tend to occur in more rural areas that you're able to connect and to aggregate. So maybe one reading of the narrative of the COVID in Latin America is how good is the urban life, right? So it's the urban paradox, and that needs to be revisited, and what are the essentials that ought to be covered to guarantee a good life and not a reactive health system.
Also, this question is for you, Professor Sunanda. You talk a lot about the community workforce and how is it like and how much success there is in Africa.
I think that where there has been investment, and I don't know that this is necessarily government investment, but where communities have strengthened themselves, then there are examples of how they've been able to respond, but particularly between that interface between the community and the formal primary care structures. So we have a lot of examples in African countries where you've got dedicated primary care staff who've been working with communities for a long time and have been building through primary care programs, MCH, TB, HIV. HIV was a very important one that showed how HIV activists working with primary care structures really promoted the whole issue about education and protection. So where there are examples of people working together like that, but it depends very much on having stability. Where you have the workforce changing every 2 years or 3 years, it's very difficult to sustain that. And I think that there are examples, particularly with the COPC work in South Africa, that show that where the workforce is trusted by communities, they have been able to make progress. Perhaps people are not writing enough about that, and we need more operational or action-based research on the successes, so that we don't keep talking about the failures, because there are successes, but they may not be in the public domain.
Thank you. And because of the time, we have rooms for only the last question. For Dr. Jaime specifically, considering the mentioned condition of Peruvian and related middle income countries' health system, how can we use telemedicine to improve primary health care and public health?
I think there's an opportunity. There's an opportunity to engage and to engage meaningfully. Remember, the starting point of the primary care in many Latin American settings is of very basic services. And so I think there's room to improve a lot, whereas in other settings that may be already more saturated, integrating. Here I'm contravening myself because I show you these pictures, slides of not adding more things to these buildings of the health system. But I think perhaps primary, on the primary health level, given its starting point, it has more room to accommodate some of these avenues, such as telemedicine and engaging with people, not being reacting to those who come and knock the door of your service, but more on a reaching out type of activities.
Thank you very much. And we come to the end of the webinar for today. In summary, I can see that COVID-19 has been challenging throughout the last 2 years, and it has highlighted the need of strengthening of primary health care. Although at the moment we see the inequality gap widening, it's opened more chances and opportunities for us to strengthen and highlight the need to empower and improve the health system through primary health care, multidisciplinary teamwork, and collaborative work of everybody in the society. Thank you very much for this evening and for everybody's attention and invaluable question. Good evening, good afternoon, and have a good day. สวัสดีค่ะ
Thank you. Gracias.
Muchas gracias.
Thank you very much.
Thank you very much. And thank you for organizing this. This is an example of IT working.
Indeed. And thank you for all the participants as well for connecting and for their questions.
It's great webinar.
It's been recorded, yes? So will people be sent a link to the recording?
Yes, it's been recorded. And if everybody could send their one-liner about the webinar to Dr. Sairat for the blog, that'd be great.
Pardon?
For the blog if everybody could send a one-liner or like a short summary to you, that would be great.
Yeah.
Well, thank you, everybody, and thank you, Sunanda and David and Sarah for.
Thank you, Praveen.
Thank you very much.
Thank you, Jaime, Sunanda, and David, and Manushi. Thank you for the invitation. And there's a lot of learning points for today, and I will share with you the summary of the today lessons.
Great. Thank you.
Thank you.
Thank you.
Bye for now.
Thank you, everyone.